Uh, Hello friends, good evening, and my name is Dr. Vikas Dua. I'm a consultant pediatric hemato-oncologist and a bone marrow transplant physician in Fortis Memorial Research Institute, Gurgaon. And with me is Dr. Mansi Sachdev.
Hi friends, I'm Dr. Mansi Sachdev. I'm a pediatric hematologist, oncologist and a bone marrow transplant physician at the same institute, Fortis Memorial Institute of Research in Gurgaon.
So friends, just to tell you that what a pediatric hemato-oncologist does. So we look after children who have blood disorders, who have cancers, or those who need bone marrow transplants. So blood disorders can be simple blood disorders like anemias, or can be complicated disorders which require bone marrow transplant. And other than that, as we are pediatric hemato-oncologists, we do see certain types of cancers which are seen in pediatric age group, like I would say neuroblastomas, brain tumors, solid tumors like Wilms tumors. So this is the area of expertise what we have. So as today's discussion is on pediatric hematological disorders and pediatric bone marrow transplant. So let me tell you, the most common reason why people come to us is because their kids are pale. That means the hemoglobin is low. That condition is called anemia, and very rarely I would say they do come to us with a condition called polycythemia. That means in which the hemoglobin is high. So that is something which is seen in adult age group. But yes, we do see certain patients who have high hemoglobin, which is called polycythemia. So when we talk about anemia, what we need to know, what are the common causes of anemia? Why the child is pale? Why is the hemoglobin low? So the most common cause of anemia in our part of the world, or I would say throughout the world, is nutritional deficiency. So among the nutritional deficiencies comes iron deficiency anemia. That means your iron level in the body is low. Sometimes your vitamin B12 level is low, or your folic acid level is low. So that is called nutritional anemias. If that is not the case, then there are certain other cause of anemias like hemolytic anemia. That means the red cells are breaking down. So when the red cells are breaking down, it could be a membranopathy. That means the membrane of the red cell is not well. The common cause for that is hereditary spherocytosis. If your membrane is okay, then sometimes you may have an enzyme deficiency which is called enzymopathy, and the most common enzymopathy in the world is G6PD deficiency, and the second most common is pyruvate kinase deficiency. If that is also not the case and the child is having hemolytic anemia, then we should look for hemoglobinopathies like thalassemias and sickle cell anemia. So usually these hemolytic anemia patients come to us with sudden drop in hemoglobin. They are jaundiced. That means the eyes are yellow. When we examine these patients, they have a spleen which is palpable, and then we order a complete blood count and a retic count. The retic count is high and the peripheral smear shows evidence of hemolysis. Then other reasons of anemias could be decreased production. That means these red cells are being formed in the bone marrow, and there is something wrong in the bone marrow which is not letting the red cells to be formed. And the most common cause for that is aplastic anemia. Other than aplastic anemia, there are certain genetic disorders like inherited bone marrow failure syndromes, in which among those the most common is Fanconi's anemia, which can cause decreased production of red cells. And last but not the least, among the causes of decreased production is diamond blackfan anemia. That means congenital pure red cell plasia. That means the red cells, just the red cells, are not being formed properly. Other reasons, as we are pediatric hemato-oncologists, we do see a lot of cancers, and people do come to us with the problem of leukemia. So the most common cancer in pediatric age group is acute lymphoblastic leukemia. It's a type of blood cancer, but in today's date, there are high chances, more than 90 to 95% chances, that the child would be fine forever if he gets proper treatment for leukemia. Then certain inherited metabolic disorders do lead to anemia. And last but not the least, among the cause of anemia, we need to understand there are certain chronic disorders like congenital heart disease, chronic renal failure, nephrotic syndromes, which can lead to anemia. So this is in a nutshell. I was telling you about the causes of anemia. So today, Dr. Mansi is going to tell you about the common indications of doing a bone marrow transplant in pediatric age group.
So the two main indications for doing a bone marrow transplant in kids it can be divided into two major causes. One is benign diseases, and the other one is malignant diseases. So benign diseases meaning non-cancerous illnesses. For example, you all would have heard about thalassemias. So thalassemia is one. The other one is sickle cell anemia. Then there is aplastic anemia, for which we do bone marrow transplant. So these are some of the benign disorders for which bone marrow transplant works. And there are certain malignant conditions for which we do bone marrow transplant. So relapsed ALL or high risk ALL is one indication for malignant, one indication where we do bone marrow transplant. The other one is any kind of leukemia. So if you have a relapsed AML, acute myeloid leukemia, or a high risk AML, or in other words, there is an entity called FLT3 positive AML. So those are some of the indications of leukemia where we do bone marrow transplant. If you have a patient who has CML and it has relapse, so we do bone marrow transplant for that as well. Especially in younger kids, we see neuroblastoma. So if you have high risk neuroblastoma, that is an indication for doing a bone marrow transplant also.
I think, Dr. Mansi, people sitting out there and those who are listening to us, they must be eager to know how we do a bone marrow transplant, who actually becomes the donor when we are thinking of doing an allogenic transplant.
So for bone marrow transplant, so let's again talk about what are the types of bone marrow transplant that we can do. So the first one is allogenic bone marrow transplant. So that means that the stem cells are taken from not the patient, but there is a separate donor. And the second one is an autologous bone marrow transplant, which is basically for solid tumors in young patients, where we can take their own cells, give them high dose chemotherapy, and then give their own cells for the bone marrow to recover. So let's talk one by one. So when we talk about allogenic bone marrow transplant, what we are talking about is we have a donor. So the preference is given to a sibling. So if you have a matched sibling for that patient, that will be our first preference. The second one would be, say, if we don't have a matched sibling, then we would try to search for a match unrelated donor. So there are certain registries, like in India there is DA3, and there is a German registry as well, like DKMS. Otherwise there is a US registry where we can search for donors, and if we find a match unrelated donor, that would be our second best donor that is available. If we don't have a matched sibling donor, like a sister or a brother who's matched, or a match unrelated donor, then we can go for a half match transplant where we take mother or father as a donor.
So this is how, friends, we select a donor, and we need to understand that somebody who requires a bone marrow transplant and doesn't get a full match donor from the brother or sister, so still they have a chance that we can get a donor from outside the family from an unrelated donor registry, or we can do a half match transplant by taking father or mother as a donor. So we need to understand that 50% of genes comes from father and 50% of genes comes from mother. So father and mother cannot be complete match. But there are techniques, there are ways by which we make these half match transplants quite safe and effective for the needy people who require bone marrow transplant. So this was in a journal about bone marrow transplant. Now let's talk about the common blood disorders. The common blood disorders are nutritional anemias. I just told you that iron deficiency, folic acid deficiency, and B12 deficiency causes anemia in our kids. So what is the reason for that? So when we talk about iron deficiency anemia, which is the most common cause of anemia in our part of the world, ideally either you have a decreased intake, that means the child is not getting sufficient iron in the diet. If that is not the case, then the child might be having some absorptive issues. So that is called malabsorption syndrome. That means the iron is not getting absorbed in your stomach. If that is also not the case, then probably you are losing iron from the gut. That means the child might be having some occult bleeding, or there is worm infestation inside your gut, which is leading to iron deficiency anemia. And the easy way to correct that, you just need simple syrup or tablets or capsules to correct your iron deficiency anemia. So you need to continue these iron supplements for 3 months. Similar is the case for vitamin B12 deficiency and folic acid deficiency. If you have low levels of B12 or folic acid deficiency, you can just take oral medicines or injectables to correct that. So coming to the genetic disorders. So the common genetic disorders which causes anemia in India, I would say, or in this part of the world, is thalassemia. So thalassemia is a genetic disorder in which from 6 months of age the baby requires monthly blood transfusion. So after the age of 6 months the baby is getting monthly blood transfusion for the rest of the life. So what is the way? What is the way forward to cure this? As Dr. Mansi just now highlighted that thalassemia can be cured with bone marrow transplant. So if you have somebody in the family who is fully matching, or you find an unrelated donor, or if that is also not the case, after discussing the pros and cons of a haplo transplant, you can correct thalassemia by bone marrow transplant. Then a common problem in Africa, which is called sickle cell anemia. So Dr. Mansi is going to talk about sickle cell anemia and how we can correct that.
So again, sickle cell anemia again is a genetic disorder where your hemoglobin is low, and sometimes you can get pain crisis. So small kids having pain everywhere. They can have big spleen. They can have a stroke. So all these things can happen with sickle cell anemia. But at this point, the only cure for sickle cell anemia is also bone marrow transplant, and it goes without saying that if you have a matched unaffected sibling, that is our first choice. If not, then match unrelated donor we can search for, and if that is also not available, then definitely we can do a half match transplant after discussing it with the parents. What are the advantages and disadvantages?
So friends, there are a lot of African people who come to us for bone marrow transplant, specifically from countries like Uganda, Rwanda, Burundi, Congo, Nigeria, Zambia. So these countries are flooded with sickle cell anemia patients, and these kids are really suffering. So the moment these families come to know about bone marrow transplant and they are ready with the funds, they fly to us. And in today's date, if we do a bone marrow transplant for sickle cell anemia and if we find a full match donor, there is a 90 to 95% chance of cure. That means 90 to 95 patients out of 100 would be fine forever. No pain crisis, no chest syndromes, no strokes, a good quality of life, and going to school like other kids. So a message to our African friends: if you know somebody in your community, in your family, who is actually suffering of sickle cell disease, please try to convince and refer them for early bone marrow transplant. We don't say we are the best, but we do close to 120 transplants in a year. That means roughly 10 to 12 transplants in a month, and out of those, roughly 30 to 40% patients are of sickle cell anemia. So please remember, sickle cell anemia can be cured forever. Then a word about leukemia.
Sure. So in kids, like Dr. Vikas has already highlighted, the most common cancer that we see in kids is acute lymphoblastic leukemia, and the most common signs or symptoms that we see in these kids is, just in general, fever that is not going away, or the child is looking pale and has some bruises on his legs and other areas where they are unexplainable, meaning that the child has not fallen down and you see, say for example, on the chest or on the back, you're seeing big bruises, so that's a cause of concern. So we always advise to go to a pediatrician first. If any of these things are happening, the child is just not feeling well, is very tired, is sleeping more than usual. Those are some of the signs and symptoms that we do see, or you can see some, swelling in the neck, or your abdomen or the child's abdomen is swollen, and we're not sure what is going on. Please, guys, go to your pediatrician. I'm not saying that you need to come to us. First, go to your pediatrician and get it checked out, because a simple blood test like a CBC would tell a lot about what is going on inside. So things that are just prolonged and they are not going away in a timely fashion, and that needs to be checked out. The other leukemia that we see in children is AML. ALL is more common, and ALL is not as common, but we do see a lot of children with AML as well. So the bottom line that I want to talk to you about in leukemias is that, if we have like 100 patients with ALL, about 90 to 95% of those children are curable in this date and age, because we have really good medicines, and the myth that children have cancer and they've done something wrong, or the parents have given something wrong to the child, that is a myth. We don't know why this happens, but it does happen and it is curable.
So please friends, do remember one thing, that cancer is no longer a death sentence, at least in pediatric age group. You have high cure rates. ALL, the most common blood cancer, 90 to 95% cure rates, means practically I would say almost